Share screen.
Hi, everybody.
Can you
good
see
evening,
it?
sir. Good evening, sir.
No, sir, we cannot see your screen, sir.
Am I
Still cannot
visible
see
and
it.
audible?
Yes,
Yes,
sir.
sir.
Sushil, sir. Yes, definitely.
Hello.
Just we are waiting, Milind sir to start. He is finding difficulty to share the screen, so we are just waiting for it.
Okay. शीरा मेरे यारा मजा आ गया तेरे को देख के
माय डियर पैटिया, तेरी आवाज में ऐसा लग रहा है कि तू इंग्लैंड में बैठा है।
इंग्लैंड में मैनचेस्टर में बैठा हूँ ठंडी में
बैठे रहो भैया, बैठे रहो।
हर्षद पारिक के गांव में बैठा हूँ हर्षद पारिक के प्रेस्टन के बगल में बैठा हूँ
Enjoy.
आज
Can you
श्रीधर
see?
how are you?
Enjoy. Manchester is good place.
Still not able to see it?
No, sir.
Sridhar, your audio is off.
Yes, I
Shubham,
know.
Shubham, can you help, sir, for the sharing this?
How are you?
I'm fine.
Enjoying a holiday?
Can you click on the share button,
What's
which is
time?
available in the bottom? Green button.
Yeah, share screen, right?
Yeah, click on that button and select the screen which you want to share.
Yeah, so the window, this is my
Click on the
Microsoft.
entire screen, okay?
Okay, click on the entire screen.
Okay, then there is option share. Click on that button.
That is not lighting up. When I go to window, it is lighting up only, then it's lighting up.
First select the window, okay?
Okay,
And after that, there is a button in blue color. There
Yeah.
is, okay,
it
click
says
on.
share. And then I'm sharing it, clicking on it. And it says sharing a window. It says that it's sharing, but it's not seen by you guys for some reason.
बीमार हो गया मैं पूरा दिखने लग गया मेरा रेसिडेंट हुई। एक्सेप्ट करना पड़ेगा।
Good evening, Paresh, sir.
Hi, good evening, everybody.
Sir.
Hi, glad to see everybody. Hi, Sushil.
Hi, dear.
Good to see everyone.
Good
Yeah,
evening, sir.
yeah, hello. Hi, Atul is there as well. Wow.
Hi Paresh,
Hi.
nice to see you.
Yeah, so many people. Yeah. It's been a long time and unfortunately I've been not been
Can you
able
see it
to
now?
join MCNS meetings. Yeah.
No, sir, we are not able to see.
मध्ये आहे मी 9:30 नंतर
Okay, let Paresh go ahead. I'll log in from other laptop. Maybe there is some issue with this laptop.
Yes, sir.
Okay.
So, Paresh, sir, we will start with you.
Okay. I am okay. Yeah. So you allow me to share the screen? Okay.
Sir.
Sir, we can
Milind,
see
sir,
that.
your screen is now seen on our screen.
You can see it?
Yeah. Cancel thing. Yeah. Now just make it. Yeah.
You can
Okay.
see it now?
Okay. Yes, sir.
Okay. So, central neuromodulation for pain. Pramod talked to me about what are the different types of central neuromodulation we can do for pain. And there are a lot of neuromodulations that can be done for chronic pain, and they all don't involve surgery. Some of them are medications, even meditation. There are some variable cranial devices, even spinal procedures like spinal cord stimulation and peripheral nerve stimulation. They cause intracranial neuromodulation and not intraspinal. But for purpose of today's talk, I'm just going to limit myself to lesioning, DBS, and motor cortex stimulation. Before we go to the procedures as such, it's important to know your patient. Chronic pain, the commonest mistake that we do is equate acute pain with chronic pain. Acute pain is a completely different animal, and chronic pain is a completely different animal. chronic pain is a disease. It's not a symptom. Acute pain is a symptom. So you got to know your patient. You got to know what type of pain it is. Neuropathic pain is something that responds the best to any neuromodulation. Nociceptive musculoskeletal second. Visceral pain third. Distribution of pain, hemi-body pain will respond to any kind of neuromodulatory effort very poorly. But if the area of pain is limited to a certain part of body, then it's more likely to respond to any intracranial or even peripheral neuromodulation. When there is associated sensory loss and allodynia, peripheral neuromodulation generally fails. Central neuromodulation does work in these patients. It's important that all these patients have neuropsychological testing. They're generally obvious red flags when you do a trial of these implants. Whenever the patient tells you that there is complete improvement during trial, 100% benefit, you should be a little bit skeptical because these are placebo effects, and these patients most certainly come back after 3 months with the same pain. Generalized pain, psychiatric problem, gains, ongoing litigations, all these things are kind of subtle red flags when it comes to chronic pain patients. You also have to tune up the expectations. You got to tell them you will see about 50% benefit in about 50% of patients. And it's not so much, but it is to an extent applicable now to India, the insurance issues. These are off-label procedures, and sometimes insurance companies will deny it. Overall trend in pain surgery is kind of going from more invasive to less invasive. So nowadays we do DBS in place of lesioning, PNS in place of motor cord stimulation, palms in place of DRES, transcranial magnetic stimulation, virtual realities. These are completely non-invasive procedures which work as well as any intracranial procedure. Coming to the procedures in general, lesioning procedures, there was a era of lesioning in 1940s and 50s, and a lot of lesioning was done then. But today's world, the only procedure that still holds steady is cingulotomy. We've done a bunch of cingulotomies for cancer pain. We generally do it bilateral, 3 lesions, one above another, 3 rows of lesions. We also do it for non-cancer chronic pain, and in those patients, if you don't want to damage the personality of the patient, should do unilateral lesions. And we always found that left-sided lesions will give very good pain control, but they will not affect the personality of the patient to that extent. And the patient should know about it, that the person and the family should know about it, that there will be change in personality after cingulotomy. And the targeting is very, very simple. It's about 2 centimeters behind the tip of frontal horn, 7 to 10 millimeters from midline, and 3 to 4 millimeters above the roof of the ventricle. You generally do 85 degrees, 90 seconds, 10 millimeter probe, 3 lesions, 10 millimeters above each other. And these were all the surgeries that were done. I've seen some of those, I've done some of those, but nowadays we don't do this. Nowadays we do all these lesions with this fancy equipment called MRGFUS, HIFU. And we've been using HIFU in OSU and West Virginia University for quite some time now. And we used it in movement disorders to begin with. But HIFU thalamotomy, centrolateral thalamotomy using HIFU, is very effective in pain control. And it's a pretty sleek procedure. Patient goes in, comes out in an hour and a half, and you can actually test by doing low energy sonications without causing any permanent damage. Make sure your lesion is in right place, and make sure the patient's pain goes down. Generally, the pain goes down on table when you do low energy sonication. And here you do centrolateral thalamotomies with HIFU. Deep brain stimulation, I personally have experience of thalamic DBS for pain. And thalamic DBS, we've done generally 1 lead in VC and 1 lead in CL. Now, VC is nucleus ventralis caudalis, and CL is nucleus centrolateralis. And this is best seen in Morell's atlas. And CL is a long nucleus. It kind of starts behind the PC and then goes in front of the mid-commissural point. It's like a scimitar, like a sickle-shaped nucleus, with majority of the body behind the posterior commissure. So you generally target for CL about 2 millimeters behind the posterior commissure and about 6 to 7 millimeters from midline and at the level of ACPC. And for VC, you will target your thalamic targeting would go about 2.5 millimeter behind it and you get the lead in the VC. So bilateral CL DBS and unilateral VC DBS on the contralateral side of pain. We've done this for significant large areas of the body are affected, CRPS, or even for musculoskeletal pain, we have done this. Thalamic pain, we had done CL, but we haven't done VC because that area is already damaged. The second is periaqueductal gray, periventricular gray, and this is the endorphin areas of the brain. So if you stimulate them, it secretes endorphin. Actually, we had a patient who had morphine palm before, and then we did a PVG DBS, and he went into morphine toxicity. So we had to stop the morphine palm. So endorphin levels, internal morphine levels go up. Nucleus accumbens DBS was the latest one, Andre Machado, and we were co-investigators in this trial. And this is basically pain is similar to addiction. And so if you target nucleus accumbens, the affective component of the pain is taken care of. Nucleus accumbens is very good for effective neuromodulation. And this is our experience. About 45 cases of pain DBS, and the most recent basically means about 12 years down the line and still have good benefit in rightly selected patients. This is what I was telling you about the VC and CL DBS. So 2 leads on one side and 1 lead on one side. And this is just our detailed MER we used to do for CL placement of probes. This was a paper published in Annals of Neurology on the randomized clinical trial of deep brain stimulation for post-stroke pain. Again, the pain scores did not go down, but the affective component, the activities of daily living, and the scale that measures the limbic component of the chronic pain definitely improved after nucleus accumbens DBS. After DBS comes motor cortex stimulation. We used to do that quite a lot. We have about 55 patients experience. The best response we have found is for face pain, and that too anesthesia dolorosa. Patients where you cannot do anything else, motor cortex stimulation works. And it's a fairly straightforward surgery. Nowadays, you can do fMRI scan and can localize the face area or the hand area. Cannot be done for foot or cannot be done for lower extremity for obvious reasons. We have done it primarily for face, or we have done it for post-brachial plexus deafferentation pain. We used to do craniotomies, but there is an Italian group which used to put it through burr holes. This is epidural stimulation. You have to find out the central sulcus, and you find it out by putting a recording grade on the dura, and then you look for N1P1 separation, and that's your central sulcus. The lead, the area between those leads is your central sulcus. And then you put 2 spinal cord stimulator leads across the central sulcus, 2 electrodes on the motor cortex, 2 electrodes on the sensory cortex, and you stitch it to the dura. We also used to cut that dura sometimes and then reattach it, because sometimes the dural stimulation will cause localized headaches. So if you kind of sensitize the dura, or you denerve the dura by cutting around it, then the localized pain gets better. Again, once you put these in pain DBS, you do a trial, externalize the stimulators for about 7 days, and see what the benefit is. And if there is benefit, you internalize it. If there is no benefit, you take those leads out. Just passing remarks on variable external neuromodulation. There are multiple devices available nowadays. We used to do occipital nerve stimulation right, left, and center for chronic migraines. And now there is a device available which you can put on your head. And there are 2 small contacts in the front, 2 small contacts in the back, and you stimulate it, stimulates your supraorbital and greater occipital nerves, and gives you benefit in headaches. TMS is coming in big way, stimulation of DLPFC and M1. TE, transcranial direct current stimulation, also helps with chronic pain. Spinal and peripheral stimulation, as I told before, also causes neuromodulation. These are some of our patients. Patients who got very good benefit did not get S1 stimulation. So this is the S1 stimulation patient who did not have good pain relief. But this is a nucleus accumbens deactivation patient who got the patient who got extremely good pain relief. Nucleus accumbens was deactivated. Nothing happened in S1. So it's not about sensory perception. It's about the limbic sensory interaction, and that's why this was one of our papers which came in neuromodulation, was like a front page article. We showed here, we did bold fMRI and showed that the connectivity between somatosensory cortex and the limbic cortex, when it's completely disconnected or it goes down to the minimum, you get pain relief. So again, as I said, chronic pain is a completely different animal, and if you want to treat chronic pain, you need to be a good psychiatrist as well as a good neurologist, and your patient selection has to be very, very proper. Thank you very much. I think I stayed in time.
Thank you, sir. I think discussion we will take at the last. We'll move on to the next talk, that is by Dr. Farid Doshi, sir, about RF ablation for trigeminal neuralgia. Farid, sir.
Yeah, thanks very much for having me over, and it's a great pleasure to be with. Let me put my screen up, and is the screen and everything visible?
Yes, sir.
Okay, perfect. So let me just minimize this and we can get things out of the way. Okay, so the topic of today's talk is radiofrequency thermoablation in cases of trigeminal neuralgia. And my tryst with this has been since my neurosurgery residency. Sushil is here, and he knows that in Nair Hospital was one of the pioneering center where we used to perform radiofrequency thermocoagulation, and I owe my all the training, initial training, to Dr. Umesh Venkserkar, who had been a very excellent teacher for the same. So that is where we are starting, and the definition of trigeminal neuralgia, I will be taking a few minutes to put the context into place and important aspects of clinical features, which are very important because I see many times lot of mistakes happening in diagnosis and management of trigeminal neuralgia. So we'll take a few minutes to understand that, and then I will go into the surgical technique with sharing the videos. So basically, International Association for Study of Pain defines trigeminal neuralgia as sudden, usually unilateral, severe, brief, stabbing recurrent episodes of pain in the distribution of one or more branches of trigeminal neuralgia. And each one of this adjective is highly important, and we'll talk about it in the next few slides. It is most commonly seen in the sixth decade with a large amount of male preponderance, and highest incidences in starting from sixth decade to the eighth decade. 90% of the patients develop symptoms later in the life. Though because of my practice, I see a large amount of young patients also. We have treated as younger patients as 20, 21-year-old also, in fact. I had one of the youngest patient was 17 or 18 years girl. So it is more prevalent in women than men. And interesting thing is that isolated distribution of a single division is not very common. Most of it occurs in pair, V2, V3 being the most common, and then followed by V1, V2 or other combinations of involvement. As I said, diagnosis is very important. Basically, there are two different groups. In fact, I don't want to take too much time talking about the clinical aspects here. Otherwise, there are 6 different subclassification of trigeminal neuralgia. But for our routine clinical practice, the two important are idiopathic and symptomatic. Idiopathic, where we basically define that as a neurovascular compression. Symptomatic is where we understand that it is accompanied by some other disease conditions that leads to trigeminal neuralgia, starting from multiple sclerosis and going up to some intracranial lesions. Now, as I said, the diagnosis of trigeminal neuralgia is the most crucial First of all, it has to follow the distribution of the division of the trigeminal nerve. And usually, if you put your 3 fingers like that, you will be able to differentiate. That is the distribution. Second common mistakes that occur is when the patient says he's getting pain here, you have to ask him whether it is in the front of the head or the side of the head, because you see here that the blue bar or the goes all the way right behind the ear, in front of the ear, all the way to the top. So it could be the V3 division and not V1. So you have to make sure which particular division of the trigeminal nerve is involved. The second important aspect is, and this again is the teaching of Dr. Umesh Vengsharkar, it has to be a lancinating pain. It comes like a shock out of the blue. That is the sign the patient has to say. If the patient tells you that, sir, continuous pain है, मैं हाथ पकड़ के बैठा हूं, that pain has to be investigated differently. The long-standing trigeminal neuralgia, you may get some of this, but the characteristic of the trigeminal neuralgia, by definition, has to be a lancinating shock-like pain. It is evoked by trigger. So the second important criteria to make a correct diagnosis is trigger. Lancinating pain, trigger, distribution of trigeminal nerve. Then there is always this disease has exacerbation and remission. So many times when you start medical treatment, patient gets relief, and sometimes it goes into remission. If it goes into remission, you can taper medication and take him off the medication. If the disease, the pain occurs, you can start again. And the medical line of treatment remains carbamazepine. First, second, third, fourth, and fifth line of treatment is carbamazepine. After that, the rest of the medication starts. So if your patient is not responding to carbamazepine, you want to reconsider your diagnosis sometimes. And obviously, the neurological examination has to be normal. There are several differential diagnoses here, and the most common I have highlighted slightly, which can confuse with trigeminal neuralgia, is a glossopharyngeal neuralgia, trigeminal neuropathy. I told you that continuous pain, burning pain, aching pain are not trigeminal neuralgia pain. Long-standing trigeminal neuralgia can leave you with a trigeminal neuropathy, but otherwise it's not. Atypical trigeminal neuralgia, we will not go into that. The rest of the things are many oral and perioral area involvement, which can cause pain, including giant cell arteritis. The second important requirement for diagnosing trigeminal neuralgia is for two reasons. One is you want to rule out an intracranial mass lesion, and second is sometimes you want to establish a neurovascular conflict. Now, as I will tell you in a few minutes, every neurovascular conflict is not a patient of a trigeminal neuralgia. When you see a neurovascular conflict, there are two things that you want to see. One is just a proximity of the neurovascular bundle to nerve bundle to the neurovascular to the root entry zone, and second is actual anatomic distortion. The diagnosis of trigeminal neuralgia is more confirmed or more confirmative when you see both together. Second, neurovascular compression in asymptomatic cases can range from 25 to 74%. And for every one patient of trigeminal neuralgia with neurovascular compression, there could be 400 asymptomatic people. So neurovascular compression per se itself is not the diagnostic criteria. The diagnostic criteria is the clinical presentation. Just 1 or 2 minutes on glossopharyngeal neuralgia, because this is very confusing, and I have seen many patients suffering, wrongly diagnosed as trigeminal neuralgia. The way to find this out is that the patient will say, sir, when I swallow, I get a pain. I get a pain in the throat. If the patient says that I get pain here, you have to be very particular and ask him, is it above the jaw or below the jaw? Is it above the jaw or below the jaw? The glossopharyngeal pain will always come here. It will be here. It will be associated with swallowing. And one of the acid tests or the beautiful test is that you can use those lignocaine spray, which anesthetists use it to spray the tonsillar fossa, and the pain of glossopharyngeal neuralgia will go on. Diagnosis of glossopharyngeal neuralgia is a clinical, and with this help of the test, it is actually having a very low incidence, so you don't have to worry in a regular clinical practice. But if you are seeing a large amount of trigeminal neuralgia, you would get this kind of patients in your clinical practice. Obviously, the treatment for that is again very select. It's a tricky thing to do, radiofrequency lesioning. I would prefer a microvascular decompression if I can establish a neurovascular conflict at the root entry zone. So now we come to the main part of the talk, and that is the surgical interventions. And there are several guidelines. All the guidelines, the American Association of Neurosurgeons and the European Federation of Neurological Surgeons all suggest that we have level C evidence for even microvascular decompression and for other peripheral decompressive procedure, including radiofrequency rhizotomy. Coming to the radiofrequency rhizotomy, it is basically a coagulation of the trigeminal nerve at the level of the Gasserin ganglion through the foramen ovale. Basically, it will leave hypoesthesia in the distribution of the affected division. Here you can see that the needle is cannulated through the foramen ovale to reach V1, V2, or V3 division. Usually V1 radiofrequency ablation is not suggested or advisable. So how does the procedure of RFTC occur? It is the Hartel's technique. We use the Hartel's technique to cannulate the foramen ovale. We use anteroposterior, lateral, and submental views to find the foramen confidently, and it is done under local anesthesia. So here you can see that this is a lateral view. There is a clivus, and the needle is here at the junction of the petrous and the clivus bone, and this is mainly targeting the V2 division. This is an oblique submental vertex view. This is a spatial view that my team has defined because of our experience and trial and error and struggling to get a good foramen ovale cannulation and view. This is a particular view where we extend the head and turn the head to a little, rotate it so that we can see this foramen ovale in line of the petrous bone so nicely. And we can cannulate it, and you have to cannulate either the middle 1/3 or the lateral 1/3 of the foramen ovale to target it. Once you are cannulated, you use the stimulation radiofrequency lesion generators to stimulate the nerve and then perform a lesioning. As I said, it is done under local anesthesia. Sometimes we use short-acting propofol anesthesia, IV anesthesia, if the patient is uncomfortable to let us cannulate the needle, and we make sure that the patient is checked before and after the lesioning. So let me show you the exact procedure. This is a special RF needle. The exposed tip is 5 mm. We use 5 mm for single division. So when you are cannulating here, you try to pierce to the outer cheek with your finger inside the cheek to make sure that you do not pierce the inner mucosa. And once you go medial to the mandible, then you can remove your finger and blindly cannulate. We have to now remove the parallax spinning on. So we are trying to remove the parallax, and you can see this external auditory meatai here both. And in the next picture, you will see that we have superimposed that, because if there is a parallax, then you cannot define the level of the needle accurately. You can see that the external auditory meatus are superimposed, and my needle is way anterior. So I will target the needle little posterior now in that direction. That is my direction that I want to go. Yeah, it will go ahead. So now I'm in the right trajectory on a lateral projection. Pause. I will now turn the CR and try to get an oblique anteroposterior view along the line of the needle. Look at the CR position. Extend the neck a little bit. Should oblique view. You can see the mandible here. This is the mandible. And the foramen is somewhere around here. We'll be cannulating the foramen. Pause. So that is how we cannulate. Once we are cannulated, we stimulate before making a lesion. Some tingling. As soon as you get tingling, you have to lift this hand up. Okay? When you start the stimulation, the patient may feel a jerk. Get tingling? Please lift your hand up. Are you? Yes. Pause. Okay. Is the tingling here? Hello? Wow. Okay. Peter? Yeah. Is the tingling here? Here? No. Show me with your finger. Where is it? There. Okay. Is it coming here? No. Is it coming here? No. In order to avoid corneal anesthesia, it is very important to ensure that the V1 division is not having any tingling. Was the tingling in the distribution of your pain? Yes. Yes. So once the patient gets some tingling, so once the patient has confirmed that it is in the distribution of the pain, you can give a lesion. We will be giving 2 lesions at 75 degrees centigrade for 60 seconds and 1 lesion at 80 degrees centigrade for 60 seconds. I prefer to give 3 lesions. It's a little overkill, but my long-term experience has shown that I require that 3 lesions to get a long-lasting relief. Started now. So that is how the lesioning is done. And after the lesion, you check, wait and lesioning is done under general anesthesia, IV general anesthesia. So once the patient wakes up, you stimulate, check out for test. The patient is awake. Me too. Are you awake? Yes. She has to be considerably responsive before we start stimulating or checking out. And we check with a pin. We don't check with an injection needle. So usually I use this pin or U pin. So Mithu, tell me if you feel pain here. Is it hurting? Here? You feel it? Yes or no? Yes or no? Mithu? No. Here you feel it? We do it again. Mithu, you feel the sharp pain? Yes? Here? No. Here? Here? Are you feeling? Sorry, tell me, little. Yes. Here? Here? Mithu. So we have achieved what we wanted, complete analgesia in V3 and hypoesthesia and hypoalgesia in V2. These are the complication rates of radiofrequency thermocoagulations at various levels and various series. Dysesthesia is one of the most longest complication. We aim to get hypoesthesia, so we get it in 23% of the patient. In our series, we had corneal anesthesia at the lowest of 1.5%. Anesthesia dolorosa again has been very low. It's a severe pain which is replaced by which replaces trigeminal neuralgia pain because of severe analgesia and anesthesia in the region of the lesion division. And at Just Look, we looked at 63 patients as a prospective trial to see what are the causes of recurrence, and we found that the patients who had typical trigeminal neuralgia had a lowest recurrence rate of only 3%. Whereas patients with little atypical characteristic pain or long-lasting trigeminal neuralgia had a much higher, almost ranging up to 32% recurrence rate. So another thing that we looked was the influence of previous radiofrequency thermocoagulation. We have repeated thermocoagulation for 3 or 4 times in many patients, and we found that If the patient had no previous thermocoagulation, then the success rate is almost 96%, which drops down to 45% if there is a history of previous thermocoagulation. And if the recurrence had to occur, when would it occur? Or what kind of pain would the patient perceive it again? So this is a VAS score before the procedure of 8.8. And the patients who recurred also had initial relief, but then they recurred in a few weeks. Whereas the patients who continued to remain pain-free for a very long duration. Long-term results of RFTC and microvascular decompression somewhere come close together, but sometimes you have to repeat the procedure. The most advantageous part of microvascular decompression, it doesn't leave any sensory deficit. With that, I would like to end. Thank you.
Thank you, sir. It's a fantastic presentation about the RF ablation for trigeminal neuralgia. It's really mesmerizing, sir.
Thank
We
you.
appreciate the presence of Dr. Kishore Chaudhary, Dr. Harshad Parekh, Dr. Abhay Kumara. And now we will move on to our next lecture, that is the pain management in lumbosacral region disorders by Dr. Ranjit Deshmukh, sir. Ranjit Deshmukh, sir.
Good evening. I will try to share my screen. Good evening, everybody.
Good evening, sir. This screen is not still shared, sir.
Yeah, just a second. Is it seen now?
No, sir, not yet.
So, can somebody help me?
Yes. Shubham?
Go down to the green, this
Yeah.
display on your
Yes, sir.
screen, the green share screen.
Yes, sir.
And
That
then your
much I
computer
tried.
screen will come up. And once your computer screen comes up, select the presentation. Can you see your desktop?
Yes, I can see my desktop.
Can you see your presentation in it?
Yes, I can see.
Now click on the presentation. Is it opening?
Yeah, I already clicked on it.
So then you have not shared the screen. Now it is starting.
Now
It is
it's
coming
yes.
now. Yes.
Yes.
It is there. Now make full screen.
Okay. Yeah, so sorry about the topic name. I gave it to Sarang a little late. So my topic is injection procedures in lumbar spine. Lumbago and leg pain. It's a big cake and everybody wants to have a piece of it. And now we have to fight not only with these people, but our spine surgeon fellows and physiotherapists like key spine. So a lot of pain clinics are coming up and few are doing really good work. We have a lot of things to learn from them. And actually I started learning these injection procedures from one of CIPM of Kailash Kothari. And then during endoscopy, I got trained further. So basically, we can divide the primary pathologies in spinal pain in primary, then referred pain and systemic. So once we rule out this serious pathologies, cancer, infection, systemic, and rule out cauda equina syndrome, then we move to the primary lumbar pathology, and these are the structures which are involved. So in young age, usually it is the myofascial structures, lumbar sprain, what we call, and as degeneration sets in, discs and zygapophyseal joints get involved, and then we have to, in confusing cases, differentiate from SI joint, vertebral pain, osteopenic pain. Neurogenic is usually easier to diagnose because we are good at it, and usually there is some radiological evidence. So this is some algorithm. Obviously, patients who do not have much of radiology and they keep on coming back, we have to go back to our old vital signs. Initially, they were 5, now they are apparently 8, and try to rule out if the patient is maligning. So we start with history examination, then we order relevant imaging. Nowadays, patient walks in with lot of X-rays and MRIs and CT scans and whatnot. If everything is concordant, then the diagnosis is usually straightforward. Then you have a treatment plan, conserve or operate or send to somebody else. If it is non-cordant, one situation like a patient who has chronic back pain, who has been to different people, different surgeons, he has undergone physiotherapy, conservative treatment, and the scans or MRI does not show instability. It shows some desiccation, and you cannot focus on it. In that scenario, I think diagnostic procedures, diagnostic injection procedures, they have a certain role if used judiciously, and if you have at least some idea what you are looking for. Like a patient has a zygapophyseal catch, you are going for a facet. If a patient has axial loading, you are going for some disc pathology and like that. So these are various injection procedures. Epidural steroids, transforaminal injection, facetal block, median branch block, intradiscal procedures, sacroiliac joint block. We don't do all of them routinely. So I'll basically talk about those which we do routinely, transforaminal injections and medial branch blocks. So this transforaminal injection technique is, I think, something which everybody who deals with spine, whether he does endoscopic or does not do endoscopic, you need to learn it and master it, and it will give you a good advantage over a period of time. You don't need to call pain physician. You don't need to send your patient to somebody else to get your diagnostic or therapeutic procedures done. So injection procedures can be broadly divided into diagnostic and therapeutic, as I told. First, about some basic things. This is a Chiba needle, 18 gauge needle. So we don't use a smooth tip needle. We use a beveled needle because we want the needle to change the direction. So needle is arranged so that there is a hub at the end, and the tip of the bevel is exactly opposite to the hub. So when you want to push the needle to right, you put the hub to left and just push, and the needle will move to right, and vice versa, up and down. And that is very important when you are targeting small areas like foramen under fluoroscopy. Now, there are a lot of pain physicians who do many procedures under ultrasound guidance, but we as surgeons are basically used to X-rays, and we do it under X-ray guidance. So this is anatomy in AP and lateral. So the most important thing, I think, in anatomy is understanding the pedicle, the lateral pedicular line, number 3, the medial pedicular line, number 2, and the mid pedicular line. So always remember that in the foramen, in the lower part of the foramen, the neural structures are always medial or at the level of medial pedicular line. So if you do not violate medial pedicular line, it's very difficult to hurt the neural structure if you are in the lower part of foramen at the level of disc or just at the superior end plate. You should be able to identify the superior articular process with different kind of CM and CM technicians and all that is going around in OT, oblique, AP, lateral, then you get irritated. But basically, you should understand where the superior articular process is and how much distance it has left from the disc. If the disc is herniated, if the disc has collapsed, if the superior articular process is hypertrophied. So studying in sagittal sections of MRI scan usually helps, starting from the outer foramen, exit foramen, mid foramen, and entry foramen, because what you need to land in all of these transforaminal procedures is at as close as to the middle pedicular line. So starting with median branch block. So first of all, median branch block versus facetal block. Facetal block is slowly going out of favor for various reasons. First of all, uh, facetal block, even if it is positive or negative test for facetal catch or facetal arthropathy, there are no good procedures or long-term procedures which target the facet directly. So the procedure which has shown good therapeutic value is ablation, radiofrequency ablation of median branch, and it can last for 6, 8, 10 months, 1 year. So basically, each joint, apophyseal joint, is supplied mainly by the median branch of the posterior ramus, which comes from superior part, but also from inferior part. So whenever you give facetal block, you have to always target two median branches, the superior one and the inferior one. The major branch comes from the superior part of the transverse process. So you have to target in that area. And the area where you target it as the transverse process and superior articular process junction. So this area in AP X-ray. We basically use all AP X-rays and 2 AP and 2 lateral. Oblique X-rays are very confusing. So this is how it is done. You mark the midline in dead AP, then mark the disc level, then mark the junction of pedicle and transverse process, then inject local, and then 21 number LP needle you slowly advance so that at the end, the tip of the needle is at the lateral border of pedicle and in the superior part of transverse process junction. And similarly here, then you inject a small amount of local anesthesia, either short acting or long acting, and come out. In lateral, it should look like this. The needle is along the pedicle in the superior part, just above the transverse process. So if the history is relevant, there is arthropathic changes on MRI, there is no lot of instability, and the patient is not very young, because in young patients doing RF can denervate the muscle and cause further muscular atrophy. But in old patients where you don't want to operate and the pain is just facetal pain, RF does give good results. So now coming to the transforaminal injections, the thing which I wanted to talk about today. So you can do a lot of diagnostic tests, you can do therapeutic things, and you can do intradiscal procedures. So when you are not sure if there are two sort of encroachments in foramen and you are not sure which foramen is giving the pain, you can use a diagnostic lateral recess block. And if the block is positive, you can treat that foramen, especially it's for transforaminal endoscopic surgery. Then advance the needle, enter the disc. You enter the posterior part of the disc where the pathology usually is. And you can do evocative discography if you want to differentiate axial loading plane. For example, common scenario is patient walks in with a MRI where disc is not herniated and there is internal disc disruption in 2-3 different discs, modic changes. And looking at the scan, you are not sure exactly which of the disc is culprit. So you can do evocative discography, and if the disc is really culprit, you really get good positive response and concordance with this. We started ozone discolysis way back in 2008 or 9, and we must have done in hundreds with mixed results. But over period, at least I have learned about patient selection, and with good selection criteria, you can get really good results. Initially, we used to do with oblique parafacetal trajectory, where the needle used to enter in the center of the disc, directly in the nucleus, and we used to inject a lot of ozone there, which used to sometimes leak out, sometimes it used to be very painful for the patient. But over period with this transforaminal entry, I have learned to give the ozone just at the base of the herniation, just in the subannular region. And that has definitely increased the results. Another thing about this diagnostic blocks, few pain physicians or a lot of pain physicians still now use single nerve root block, where they inject the dye or the anesthetic between the inferior border of the pedicle and superior edge of the exiting root. So it does anesthetize the root, but it doesn't give therapeutic information, because then you do not know whether that root is affected because of pathology which is in the same foramen, or a pathology which is superior when the root is traversing. So overall, nowadays, lateral recess block is preferred where one traversing root and the upper exiting root is targeted in the same injection. So at least you identify with the pathology. If patient has positive response, you can directly target the pathology in the same foramen. So this is basic technique. You mark the midline, try and get a dead AP where the spinous process is exactly in the middle of two pedicles. If not so, don't turn the C-arm, tilt the table little bit so that it comes in between. This was an, hello? Sorry. So this was a patient who was already operated. There were a lot of fibrosis in two foramina, and we did not know exactly where the pain is arising from. So this is dead AP. You mark the midline, then you mark the disc level in dead AP. Then you mark something called as disc tilt or disc inclination. The affected disc in lateral X-ray, you mark a boundary line. Then there are various entries to target foramen, but those are mainly for endoscopy, whether you want to go shallow, you want to go steep, this extraforaminal central disc. For practical purpose, 45-45 trajectory is sufficient to enter the foramen and target the subannular area. So this way, at the height of the skin and with the tip of the marking rod at the anterior border of the disc, you take that height and you translate that height from the midline to lateral. Then you land up with two lines. One line is this, which is the parallel line to the disc, and this is in AP, and this is the line which is disc inclination line. So this is the distance which we measure with the rod that you transfer on this line, and this is your entry point. Anesthetize after painting, anesthetize is and advance your needle around 25 to 30 degrees medially. Always advance the needle in AP and then check in lateral where you are. It's a true AP and true lateral. So you have two images, one AP and one lateral. And from that, you have to sort of make an image of axial section where the needle is. If it is too shallow, turn the bevel down, hub up, and go inferiorly. If it is too deep, turn it opposite and go superiorly. You should try to land on the superior articular tip of superior articular facet parallel to the disc, just in the lower part or mid lower part of the foramen. And when you are here in the AP, you should be away from the medial pedicular line. So this is medial pedicular line, and you are away from that. So when you advance the needle and you reach on the posterior edge of the annulus, you are at the medial pedicular line. So this is how it is. This is the medial pedicular line. Your tip is just near the medial pedicular line, and you are on the annulus. So this is a safe area. If you are in doubt, inject a little bit of dye and you come to know where you are. If the dye goes intrathecally, withdraw the needle and come below. Usually both these roots are inflamed, and even if you touch that area, patient has significant pain. So this is the dye injected in this patient. You can see that the dye has traversed and in the anterior epidural space cephalad and exited in the extraforaminal area, but there is no dye in the along the traversing route, a very small trickle. So he has a block here and some pathology here, which definitely would give him pain relief. This is another patient, similar non-operated case, and you can see that there is again block. So usually before giving ozone, many times we do this kind of lateral recess graphy. So then you advance the needle, you go into the disc, and you either do evocative discography or therapeutic ozone. So you can see from these pictures that my needle is in center of the disc, but here it is in the posterior part. So it is just subannular or annular. So if I want to do endoscopic surgery, I can advance the dilator over here and get into the what they call inside out technique, half in, half out. So half of the cannula is in the disc, half of the cannula out, and you can work on that. So this is for alpha S1. Alpha S1 is sometimes difficult because sometimes the iliac crest is too high. You have to first mark the iliac crest, take a higher point and go oblique. Sometimes there is a large alpha transverse process and you are not able to advance into it. So this is, I'm in the medial pedicular line and on the annulus. Then I advance the needle, I enter the subannular area and I'm already in the center of the disc. So for example, this is a case where there is a small herniation, lot of modic changes and chronic back pain. Before you advise the patient any intervention, doing a evocative discography, getting a concordance from this disc is an easy and very assuring thing for the patient as well as for the surgeon. So these are various types of discography pictures. They are mentioned. Unfortunately, I could not find my own discography pictures. So these are few cases which we treated with ozone. There are a lot of cases, few failures, but even large discs, sometimes not content discs also respond fairly well to ozone. This is just entering the annulus and giving ozone in the paracentral area where the herniation lies. So sometimes, as I told you, when the iliac crest is very high and you don't get a straight epilateral view, then you can tilt the C-arm, see the window through iliac crest, transverse process, and superior facet. And in that triangle, you can put the needle dead end and you can enter the foramen or disc, lateral part of foramen. It is definitely inferior to transforamental route, but you can get and do that. Thank you very much. I think I was in time.
Yes. Thank you, Ranjit sir. As we have too many dignitaries with us, my request will be that every dignitary has to give comment on all the three topics, and if they have any question about to the speaker, they can ask right now. So we'll start with Atul Goel sir, and Goel sir. I think that Atul sir is not there, so we'll go to Patkar sir. Patkar sir, your comments, please.
Yeah, I have actually zero experience of central modulation for pain. So I
Same
cannot
here.
comment on Dr. Devgaokar's work. But of course, Paresh Doshi has been a friend and we are Guru Bandhus, and even I have been doing radio frequency for a long time. My one question to Paresh was, Paresh, you did not do any motor stimulation. Do you do or you don't do motor stimulation? You have to unmute yourself, Paresh. Has Paresh disappeared?
No, he's there, sir.
Yes. Paresh, my question, do you hear me?
A dead Lincoln is only good for the people who hired him. A dead Lincoln is only good for the people who hired him. If Prime Minister
I cannot
Nicol
hear anything.
Trowbridge
Can you
wants
hear
him
anything?
dead,
Hello. Hello,
I was
Paresh
expecting
sir.
Mr. White, if you understand. I
Hello.
don't wish to speak to
I
anyone
think
from your
Mr.
embassy.
Yes,
Mr. Grove, sorry I'm late. Mr. Grove.
Right, something
He's
is,
seeing a movie, looks like.
yeah. Now he's there.
Yes. Paresh, did you hear me? Paresh,
Yeah.
unmute yourself.
I think his
Yeah, I can't see. There is the screen say Ranjit has to first remove the stop sharing the screen.
He has stopped sharing the screen.
No. Now yes. Yeah.
Now yes.
Yes.
Sorry.
Okay.
Sorry
Okay.
for that.
Paresh,
Nobody brought it to my notice.
my question was, it was an excellent presentation. My question to you was, you do not do motor stimulation?
I do motor cortex stimulation. Yes.
No, not motor cortex, for the motor component of the trigeminal nerve.
Oh yeah. No, not what I would say preferentially. Yeah, we note it down, but I'm not much concerned about it. Yeah.
So you don't specifically do high frequency stimulation to know whether your needle is close to the motor component of the V3 root?
Usually it is always in close proximity. So you do get a mild motor deficit, which recovers.
But changing the position of needle will avoid that.
I doubt very much we are making a very good big lesion because I initially used to do 65-70 degree single lesion, which we all had been trained, and I used to do in London also and continued. But when I started clinical practice in India, after a few years, I realized that one lesion is bringing a good amount of recurrence. So I end up doing definitely much more than is required, but we have not had significant risk of long-term complications because of that. And it has given us much longer lasting outcome.
What are your comments about the recent talk of, I do not have pulse radio frequency. I use continuous radio
Correct.
frequency. What about?
So we do have a pulse radio frequency, and I sometimes use it for V1. Not for V2 and V3. V2 and V3 require stronger lesioning and longer lasting. Pulse radio frequency is by principle, it feels like it's not going to be as longer lasting, or it's not as damaging. So that is where I use V1 pulse radio frequency occasionally or supraorbital neurectomy. So I combined, if there is a V2 division plus V1, then I only lesion V2, and then probably wait for the patient to see if that has solved his problem. If the V1 pain continues, then I would probably do a supraorbital neurectomy if the patient is agreeable, otherwise a pulse radio frequency.
My last question and comment to you and to everybody. Of course, I did microvascular decompressions, but I am more happy doing radio frequency for last 25 years. My question is that the etiology is that the theory of neurovascular compression is that there is demyelination because at the root entry zone. And when we use microvascular decompression, we relieve the compression, whereas in radio frequency, we destroy the pain fiber, the C type of fibers. My question and the thought that always bothers me is that if it was demyelination, why does the patient get immediate relief after the microvascular decompression? And in radio frequency, I can understand because the fibers are burned and you get numbness immediate post-op. In microvascular decompression, how do you explain that if demyelination is the etiology, removal of the nerve immediately cures the demyelination?
Can I answer that?
Yes, please.
Yeah. So the pathophysiology, you are absolutely correct. It's a demyelination. Not only that, because of the want of time, I removed all those slides. But when you examine microscopically these trigeminal nerve roots and the nerve root entry zone, virtually all the axon or the large myelinated fibers are lost in that area, virtually, and only some unmyelinated fibers are lasting there. Now, the only way this can explain that your question can be answered is that because the continuous pulsatile impulse has been removed from that area, that continuous painful impulse or the pain inciting pathology has been moved away, the pain is not being perceived. So it's not about the pain relief is secondary to removal of the obnoxious agent rather than anything else. There is no neuroregeneration or change immediately in that part. And as compared to that, the radio frequency, obviously we are anesthetizing that area. So obviously the amount of pain impulses have been reduced here.
Another thing I wanted to add, and there are two things I wanted to add. One thing is that people more talk about now neurovascular conflict rather than demyelination and effective transmission. So maybe because the frequencies of the nerve pulsation and those with the nerve impulse, they match, and that produces trigeminal neuralgia. And once you remove the nerve, remove the vessel, that stops. That may be plausible. Second thing I wanted to ask you, what are your criteria for selection of a patient for RF, trigeminal RFLG over surgery, over MPD? I think you do both of them.
Patient decides. Patient decides. So when I was in England, I was not, we had a large number of patients wanting microvascular decompression, even elderly patients. In India, if they have an option, like Sushil mentioned, if you tell the patient the exact statistics which are there in the science, not your personal statistics. Do not cloud. I never cloud them with my personal experience or my personal bias. So I tell them these are the pros, these are the cons. You decide what you want. Even I have had younger patient who could get V3 anesthesia, which could affect their many other functions, would still opt for it when we tell them that your kissing might get affected, or you may not have the same pleasure, or you may have this long-lasting numbness for some time, which you have to get adjusted to. They take a day or two, but they come back. So the amount of microvascular decompression that we end up doing is less than 2% or 3%. 96 or 98% patients do go for this.
So I think it depends on how you sort of guide the patient.
No, that is what
You
I'm trying to tell you.
said it too.
No, you do not guide the patient. Never guide the patient. Your job is to give information. Your job is not to give them a decision. The decision has to be taken by the patient. This is our major mistake. We always tell, अरे मेरे हाथ में कुछ नहीं होता है, मेरा सक्सेस है, मेरा 100% सक्सेस है. नहीं, whatever is science. I recently had a patient whom I had worked up for depression surgery from Delhi for 6 months, and I have to take a permission from the government of Maharashtra. After taking the permission, his date of surgery was fixed. Social interesting thing. His date was fixed. He had to transfer money. He again had a call, and I told him the same statistics that I have operated 4 depression patients with 100% success, but your success rate is going to be 70% because the international statistics tells us that in the best hands, 60 to 70% outcome is there, positive outcome, and you may not benefit. He canceled the surgery. So we never tell the patient what is going to be. We have to give them the scientific, basically the update.
So as a philosophical thought for everybody, I mean, not my thought, what would we prefer? A destructive lesion, destructing your nerve, or something which is non-destructive?
I would take radio frequency.
ते तुम्ही सांगितलं सोमकाशीच. I am asking everybody. You are replying for everybody.
I'd asked in the neurology meeting. I'd asked the senior most neurologist, and the neurologist said that I will undergo radio frequency. The neurologist who refers the patients.
Majumdar sir, your comment?
Yeah, I have some points which I want to highlight. Obviously, Milind's presentation has been excellent, and it is a little bit more technologically advanced. But I would come to Paresh. Paresh, nice talk. I would just want to highlight that obviously we have just to mention that we have to do an imaging before we do any RFTC. That point has to be highlighted, and I'm sure that we are all doing it. But just for the benefit of viewers, I think because sometimes we miss an epidermoid or any other lesion, and sometimes the patient goes for RFTC. So that is one thing. Second thing is V1 neuralgia. Now what Ranjit had mentioned in this slide about multimodality treatment and multiple people from all pathies doing it. I have seen a patient with V1 neuralgia being given RFTC, and then the patient did not have relief, so I had to do supraorbital neurectomy for that patient. Now, supraorbital neurectomy, the patient was okay for 1 year. Again, the patient has started having the the classical pain that you described. Now, again, there is a problem just because there are being interventions by people who are, this has been pain management, multiple people, not surgeons. Now we are in a fix. What do we advise to this patient? Whether he undergoes rhizotomy, whether he undergoes, balloon compression and this and that. But the burning point for all of us is that when the patient comes to us, now RF for V1, you have been very careful in saying that you do the pulse for V2. V1 is a contraindication. So how do we tackle these cases? Then the message has to go clear that there has to be certain science behind everything, So that is my question to you. And the third question is, how do you compare yourself with the 3,000 cases of trigeminal neuralgia, obviously treated RFTC by the great Professor USV, and maybe he has published in his book. But after your long experience and you have been a student, and how do you compare his experience and your experience, and whether it is better matching or there are some insights.
So I'll
Paresh,
answer
can
the
you
last
highlight on this? One is
the
the
last
V1 and second.
correct. So last question first. I think Dr. Venksatkar was an excellent teacher and excellent artist. The thing is about what tools you had at what time. Now, he also had the fantastic tool and he had this. The second thing is about the long-term observations and follow-up. So I have, in fact, all his patients that had recurrence, I had been treating for last 15, 20 years almost. Even when he was there, present there, his daughter used to ask them to come back to me because sir was taking slow. So we need, all of us have recurrence, and I tell my patient that there is a 15 to 20% recurrence rate. So I never tell them that there is no recurrence, and I tell them with microvascular decompression, it is 3 to 5%. So I very clearly give them the statistics. So that is one. So it is difficult to now analyze unless we have been meticulously documenting, but even us, we have not been able to have the data for all our RFTC. So we cannot conclusively tell you that answer. The second thing is about the V1. So Dattatreya, it is very difficult to educate everybody. Yeah, it is difficult to educate everybody. RF of V1 is contraindicated. Once again, let me explain you why. It's because of the corneal anesthesia. Because the corneal anesthesia, if you get, it's a permanent damage and it is a lifelong problem for you, for your, and risk to your vision. So you don't. And to answer the second part of that question, what do you offer? That the reason for supraorbital neudectomy is coming back is all this peripheral procedure. The more peripheral you go, the more the chances of recurrence. So with the RF, you are going at a Gasserian ganglion, so that recurrence chances 15-20%. With supraorbital, I tell them, वापस आएगा ही, आएगा तभी वापस मेरे पास आना, मैं निकाल दूंगा वापस, because the nerve regenerate. So you tell them if it doesn't come, he's not going to blame you. If it comes, he's going to be prepared for it. And if you tell them before the surgery, no patient is going to go away. Don't worry. No patient of mine has left because I have told them the honest truth. They in fact appreciate and they come back.
Paresh, one sec. The point raised by Sushil and you about the demyelination versus destruction. I feel there's a third point where there is a lot of the arachnoidal encasement which occurs. See, when you open a case of for MVD, you see that there are a lot of arachnoidal adhesions there. And that arachnoidal adhesion, I think, cause pooling of CSF, and it further enhances that pulsatile component of the vessel hitting the nerve. So, because the reason is, I have found sometimes, now this is my very modest experience, that when I do a good arachnoidal dissection, that itself frees the vessel from the nerve to a certain extent. So, I'm not saying that so interposition graft is necessary, but I felt that the more you do a good arachnoidal dissection right from the apex of and downwards toward the root entry zone, more is the chance that your MVD will succeed. Of course, the interposition graft and your separation of the loop and all these things there. But I think this is a third component where the arachnoid has to be dissected, freed, so that the CSF flow is not restricted to that trigeminal system, but in the CP ankle system itself.
Yeah.
Anybody had this experience?
When everything fails, the final thing is to go and do a neurolysis.
Yeah.
So the answer lies ultimately in the nerve, where you move a blunt dissector inside the nerve when all procedures have failed.
Yes.
Repeated RFTCs have failed, repeated MVDs have failed. But at the second thing which Paresh mentioned is very important, that for every one person having neurovascular contact with trigeminal neuralgia, there are 74 who have neurovascular contact without trigeminal neuralgia. Exactly. And like Dr. Venksatkar is to say, that there are many places in the body replete with... Dr. Venksatkar is to mention that in the body there are many places where there is neurovascular contact, like the spinal cord, the optic nerve, and even the penis. and
Yeah.
where there is no lancinating pain because of neurovascular contact.
But then does that arachnoidal component come into play where there is a
Of course, I think so.
component?
I think somebody should study this where they go down in the CP angle, just release the arachnoid. Don't bother about putting those grafts between the nerve and the blood vessel and come out. And I'm sure the patient is going to be relieved.
Yeah, I know.
We would like to have a comment from Dr. Kishore Chaudhary, sir.
Excellent presentation, Paresh. Beautiful demonstration. A quick question to you. I don't know how it is in Mumbai now, but do you consider radiosurgery as a more non-invasive option for treating patients with genuine trigeminal neuralgia as the first method of treatment or preferred choice of treatment?
Yeah, so again, here, Kishore, maybe it could be my lack of full understanding of the literature and a personal experience. That has to be missed. I want to put that as a caveat. But I have been always skeptical about balloon compression and radiosurgery because I cannot, and I'm a functional neurosurgeon. So I only like to do something permanent or definitive, not even when DBS is not permanent, it's definitive only after confirmation of my target physiologically. So I do not get that pleasure of confirming the target or needle localization in radiosurgery or balloon compression, where I would be able to confidently say that I avoided V1. So my risk for V1 increases in my mind if I have to opt for blind radiosurgery. So I do ask them to go for radiosurgery, especially if they're elderly and risk for any anesthesia or who cannot be stopped antiplatelets. So there are patients which are exceptions. So patients who cannot be stopped who are on antiplatelets, severe pain cannot be stopped. We ask them for going for radiosurgery. Yeah.
And one question to Ranjit is, Ranjit, thanks very much, Paresh. Ranjit, we have a unit here. Actually, Shailen Rachwa is from that unit and he's not here at the moment. But they would not undertake any lumbar decompressions or even discectomies. I'm talking about the routine elective patients who have been waiting on your waiting list, unless they do a diagnostic nerve root block. And in a proportion of patients, that diagnostic nerve root block would also be a therapeutic nerve root block if the patient is helped by that. And unless the nerve root block confirms that there is a pain relief, and if it recurs, then only they would operate on these patients. If the nerve root block does not give pain relief, they would be very reluctant to operate on those patients. What are your thoughts about this, offering a diagnostic nerve root block?
I think doing that is stretching too much. I mean, when you have a good clinical radiological concordance, failure of conservative treatment, and still you want to do the same thing just for the sake of it, I think it is stretching too much, maybe part of protocol. A lot of patients that we operate, they are sometimes failure of ozone. Sometimes they have temporary relief with transforaminal steroids. Actually, what we do with transforaminal steroid is just buy some time. There is a lot of inflammatory component to acute disc herniation, and that is always taken away. So I clearly see difference in response to oral steroids versus response to transforaminal steroids. If your needle lands properly and you could bathe both the nerves with the dye, and that's how with the steroid. And if the pain doesn't go away, I mean, it goes away and it recurs after waning of the effect of steroid or of ozone, then it's already like we have done the diagnostic block also. But if the disc is huge or if the symptomatology is clear and there is only one level which is affected, then doing diagnostic blocks just for the sake of it, I don't think it is correct. What is your opinion, Dr. Patkar, sir?
Sushil, you unmute yourself. Sushil, unmute. Sushil, unmute.
Patkar, sir, is muted.
Yeah, sorry. Yes, I think blocks are overused by many spine surgeons. And also, I don't know, I'm not criticizing UK, but they have difficulty in getting theater slots for spinal surgery. You know, they're long waiting, so probably they are justified. I agree with you completely. If there is clinico-radiological concordance and the standard conservative treatment has been done, surgery is a quicker option to relieve the patient, and there is no need to do any additional confirmation, especially if there is a neurological deficit or there is impending chance of getting neurological deficit. I get sometimes very surprised when I see patients getting steroids for claudication and for lumbar canal stenosis. That is like, stretching it too far and, almost like cooking Sheikh Chilli ka khichdi, giving epidural steroids for lumbar canal stenosis when there is a frank compression and frank ligamentum flema hypertrophy. And I think that even patients are to be held responsible for this, because patients also, if they are offered something which is non-surgical and which is a daycare procedure, there is some element of placebo effect to it. We have to remember that in these injection treatments, the longer the duration of symptoms, lesser are the chances that the patient is going to respond. Because these steroid treatments, they help only those who have acute inflammation. And when you say that you are going to do the standard protocol, the conservative treatment period is over. And in spite of that, if the patient has, there's no need to do one more lumbar root block.
Only one. Sorry.
I would extrapolate this a little further, because again, the slide that you showed about multiple allied people interfering and not interfering, they are also, there's a lot of overlap. Now, I think somewhere spine surgeons or neurospine surgeons are I think they should be more aware now. See, when we get the patient, there has to be a certain amount of confidence to be instilled. Now, I feel personally that 90% of the patients that we see in day-to-day practice can be managed conservatively. Again, instilling confidence in the patient, talking them about lifestyle, talking them about physiotherapy, and then establishing a bond where they would come back to you rather than going to some commercial or an advertised camp where they are, they can easily grasp them. Now, the people, why they're going on all these injections and this other thing is because they feel that the spinal surgeon is not honest. Let me tell you, they will operate and they have seen a lot of failures and a lot of complications. And even though my practice spine is very limited extent, but I feel that there is a lacuna there. There has to be some amount of confidence instilled for a patient to undergo some form of discectomy or fixation or something. They feel that these are elaborate procedures. The surgeon is trying to extract something from that. Mind you, all these procedures, the direct indications are only 10%. Where I would say you require a fusion, you require a fixation, you require this and that, only 10%. But 80 to 90% of the patient can be managed, and those are your ambassadors for getting more patients into your surgical domain, as what Sushil said, that they have now failed conservative and they are coming into the surgical domain. We are missing those. Why patients are, I'm seeing a lot of people now, just the patient I mentioned to Paresh about patient taking RFTC for V1 and then coming here and then everything is messed up. You can't then do anything much, then your success rate further goes down. So I feel as in our mainstream conferences, we have to stress importance about having a bond with the patient, about keeping the patient with us. That's what I wanted to say about all this pain management. I don't know what you are all expert spine surgeons, so my experience is very limited. But I thought that I should bring up this point when Pramod told me that you become a panelist. Suddenly, I took this, that it was in my mind for the years together. But I thought that I want your experience on that.
Where is Sridhar? Is Sridhar gone away?
Sridhar is in Taiwan. Sridhar is in Taiwan. He left.
I think I also want to add one more thing, Datta. This is a very good technique. When somebody else has advised surgery for the patient, you tell the patient, we'll try a block and wait for some time. That guy will be on your side. He'll take the block from you, and in spite if he doesn't get cured, he'll feel that you are the good guy and he'll come back to you for surgery. Ranjit, am I right?
I'll try that next time. I'll try that next time.
One more question for you, Ranjit. One more question.
Yes.
Why do you think that the cervical spinal blocks for radiculopathy are not as popular or in vogue as they are for lumbar spines? Well, why is that? Because of the because they are more motor components, or because of vertebral artery, or because they are technically more difficult, or why do you think?
They are technically difficult. There are a lot of complications. Transforaminal people have abandoned. People have done and people have abandoned because of disastrous complications, root infections, cord infections, everything. People, what they do now is some facetal injections and medial branch block, multiple medial branch block for unexplained neck pains. That's what pain physicians do. We do a lot of intradiscal ozones, anterior direct intradiscal ozones. So basic problem is if it is a short neck and the disc is 5/6 or 6/7, then sometimes it's difficult to get a lateral view and put your needle inside. But middle and upper level, excellent results. I don't remember when I operated last foraminal or paracentral small herniation. I don't remember. We have done a lot of ozone. We had in 17 years 2 infections, discitis, frank discitis, which needed something further on, lavage and something. And one patient had transient blindness. Apart from that, I don't remember. We must have done altogether more than 500 or more than 1,000 ozone injections. But I don't remember serious complications. So that is
transient blindness was because of what?
Huh?
Transient blindness because of?
So Manish searched it, and it is apparently some of the ozone going in the venous or arterial system. It was little unexplained. We couldn't get it. We found some evidence, but it was not very firm evidence. But fortunately, it was unilateral and it improved rapidly.
Was it TIA from the carotid bifurcation?
So that's another possibility, but didn't have other this thing. We did an MRI also. It was clean. And about your comment on claudication, sir, if the patient has clear-cut claudication, very not well-defined, poorly localized, and there is lateral recess stenosis, which you are not very sure it's culprit or not, in that case, targeting that traversing route with diagnostic block, I'm not saying therapeutic, diagnostic block sometimes increases your confidence in offering him surgery. Otherwise, good central canal, just lateral recess stenosis, unilateral.
But how would that benefit? If we are going to accept Verba's theory that the claudication is because of venous congestion, how would a block treat the venous congestion?
So it takes away temporary pain. It takes away a lot of autonomic components of the pain.
The pain will only come on weight bearing when the patient starts walking.
Yeah, but
how would the pain go away? How would the pain go? You're not anesthetizing the nerve root.
So we are giving local anesthetic.
I'm not convinced about claudication. When there is claudication, to use
they do have 2-point improvement. So I don't know if it is placebo or not. It's used very sparingly in claudication, maybe twice a year or so, but that increases your confidence in offering him surgery. So when you are not very sure whether that lateral recess is really stenosis causing the symptoms or not.
So I think that we had a lot much discussion on all the pain management things. I really appreciate the presence of too many people in our MCNS webinar today. I thanks personally to Dr. Sushil Patkar sir, Dr. Dattatreya sir, Dr. Kishore Chaudhary sir for being as our patron and our panelists. And the speakers, of course, Dr. Paresh Doshi sir, Dr. Ranjit Deshmukh sir, and yes, my elder brother Milind Devgaonkar sir. So we have excellent discussion. This is some topic which is always remaining behind. Why to go for this? Why to go for that? And as a general neurosurgeon, I would like to say that many a times, as Patkar sir said, if you offer conservative treatment to the patient, if you say that there is no need of surgery, the patient will be always with you. So I think that is the brief vakya for today's class. That yes, first offer the conservative line of treatment. And really,
there is one more stalwart on the group, Dr. Abhay Kumar. He's
Dr.
silent
Abhay
for a
Kumar,
long time.
Yes,
has he gone away or is still there?
I think that he's. Hello, Dr. Abhay Kumar.
Sir, I'm there, sir.
Yes, sir.
No, I need your comments. You have been quiet. You cannot remain quiet.
I think that you are.
No, sir, I was listening.
You cannot remain quiet, Abhay. You have to contribute. Some final comments from you before we close?
Yeah, so a brief comment. I do as well this RFTC lesions for trigeminal, but my experience is limited. But what I've learned from my seniors in UK was that I do both the sensory and motor stimulation before lesioning and after as well. What I have seen is, and it is even my seniors' experience there as well, if the sensory stimulation or the paresthesia comes up, imagine it comes at 0.2 milliamperes, and if you after lesioning, if the sensory stimulation gives paresthesia, double the time, double the this thing of the, if it is at 0.2, if it get at 0.4 or 0.5, the chances of this working is very good. So what my seniors used to do is, if they doesn't, if he gets a paresthesia within the double that amplitude, then they used to re-stimulate again, put the patient into anesthesia, re-stimulate again till you get that. But
but Paresh did the pin testing on the table. That is a very good test. If there is numbness immediate after the lesioning, after lesioning, you're sure that you have done the good job. What do you think, Paresh?
I think that's a very interesting thing. I will try to see and use this, what Abhay is saying, to just to verify that the pinprick hypoesthesia correlates with this.
Whether that is correlated. Yeah. Yeah.
What is your opinion? I feel like the lower the current at which you get stimulation, the better that you are in the correct position.
Correct,
if you are requiring a lot of current to get the stimulation, that means your position
it has
is not
to be
correct.
less than 1 milliamp or at
Correct.
the 1.2 or 1.4 in a fresh case. In a fresh case, again, if the patient has a long-standing pain, neuropathy element has already come, it becomes very tricky. If there is sometimes fibrosis, it becomes very difficult. So I think ultimately you should try to position the needle to get it at the lowest. But if you have been able to cannulate and you have got some good correlation, then the best is give one shot of lesioning, check it out. If it works, that is fine. If it is not, then you repeat the lesion after repositioning the needle.
Atul, what is your opinion about the blocks? Atul, where are you gone?
Goel is back, I think.
What is your opinion about the blocks, Atul?
I am very much here, my dear Patty, and I have heard some fantastic. You can imagine there are several achievers in our group. One of them is, without any doubt, Paresh has achieved quite a bit in whatever he does. And whatever he has achieved, we have been watching him, we have been hearing him, we have been seeing him. And it is indeed a credit to him and to all of us that he has gone that far. You agree, Patty? What do you think?
Of course, no question.
In lesioning and Parkinsonism, he's amongst the best maybe in the world. So I am very proud and very happy to see him growing the way he has grown. That is one thing. Second thing is he has the same lineage as you, Patty, and me.
Exactly.
Dr. U.S. Venkserkar was our father, and he was our teacher, and he was such a great teacher. We all know that the way he taught radio frequency, nobody could have ever taught. And the way he produced results were absolutely, at that time, 15, 20 years ago, he was amongst the, as you rightly said, he was amongst the leaders of the world in RF lesioning. And the way he used to teach and the way he used to demonstrate, and of course, Dr. Patkar and Dr. Paresh, both of you have learned from him and both of you have followed him and you have progressed in the way you have to progress. And of course, Paresh has gone a different direction. Patkar has gone a different direction. As far as radio frequency, thermocoagulation, and my personal impression is, I must say that I don't do radio frequency lesioning. And I was with Peter Janetta when he was in his heydays. I spent 1.5 years in Pittsburgh with Peter Janetta. And Peter Janetta was the father of microvascular decompression. And he used to do 6 or 7 cases in one day. With that kind of workload, I had been trained with him in 1987, 88. So I have, diverted a bit from RF lesioning, and I am absolutely convinced myself. You see, we can have opinion, we can have whatever we have, but if my opinion you ask, I think microvascular decompression is the king procedure. It is the procedure, and it is such a fantastic result-oriented operation. I am not sure whether this lesioning can produce numbness, whether it can produce corneal problem, whether it can produce retro, pain after the procedure and all those things. I have not followed up that procedure, but what you are showing is indeed very creditable, and with your experience, you have shown what you have shown. And Patkar, you have said whatever you have said. But I have to say, if you ask me, I am doing microvascular decompression since the time I have been trained with Peter Janetta. And he was also one of the great teachers like U.S. Venksatkar. If you have met him and if you have seen him, fantastic. Paresh, you must, we have to respect our teachers the way they taught us. And if we don't respect our teachers, we are not students. We
Atul,
should love
can I
ourselves.
tell you that I landed at Queen Square directly from Nair Hospital, where means it was like you going from a very small pond to the large ocean. Queen Square was kind of a crazy place. And the only reason I could stand there was because of the basic knowledge or the teachings of Dr. Vengsarkar, how to read a CT scan, how to read an MRI, how to mark a scalp flap. Those things, people will feel that they are so stupid, but they are indispensable. Those teachings had been indispensable, and that made me stand with confidence amongst the other people who were so-called so well-trained or very advanced. So I agree with you and completely. Means that's how I started. I would not have been talking about RFTC if it was not for Dr. Vengsarkar sir. And then I had, like you, David Thomas, who used to do that in England.
And to go a little bit, if we have time, let me just little bit remember our teacher, Dr. U.S. Venser. He was in the days when microscope was not, he was not a microscope neurosurgeon. He was not using microscopes, but he was such a fascinating teacher of neurosurgery, such a basic, solid teacher. And his teachings will remain with all those students who have been fortunate to be with him all those years. And when I landed in neurosurgery in 1982, I landed in his department and he was operating. When I first saw him, his back, I saw him. And he was, the posterior fossa, he was doing in sitting position. And he had put a needle in the ventricle and the water was dripping like this. And I really got scared. I don't know. I thought that I will never be able to reach that destination. And when he came out with Dr. Shetty, if you remember
Yes.
Dr. Shetty, what a great personality. He was called Towering Inferno of that time. Towering Inferno was a big movie, and Amitabh Bachchan-like personality here. So both of these made me scared, and I thought I will never reach the destination and will never reach what they have achieved. So it is just a beautiful memories of those days which you have enjoyed, Dr. Patkar has enjoyed, and I'm sure some of you in the audience must have enjoyed. So we remember our teacher with great honor, great pride, and great respect.
Great conclusion.
Really a great conclusion.
Your comments about lumbar blocks, Atul, you're forgetting my question.
Lumbar block, when you talk of lumbar block, when you talk, Ranjit, when I talk of lumbar block, my brain gets blocked. You know what? And I have to tell you about pain. You must read my recent article, which is published about 15 days ago about pain. And pain is such an important symptom, pain and muscle spasm. When you have pain, when you have muscle spasm for 10 years, for 5 years, it is a response. My article, you read the title of my article, which is published 15 days ago, muscle pain, pain and spasm. These are the symptoms which indicate an unstable situation. So pain is not just like that. Pain is a symptom of a disease, of a problem. And to get rid of the pain is not such a great idea. Ranjit, I'm going away from what you have said, but my impression is removing pain is not such a great idea. You identify why there is pain. You go, and blocks is a thing which has been going on for, and another thing which has mesmerized me, which has not just taken me away, it has mesmerized me about facets. You do fixation, we do pedicle fixation, you do whatever fixation, but you do facet fixation. There is something unique in the facet. Facet has something which is out of the world. Facet is the fulcrum of movement. Facet is the point where all the movements happen. facet has something unique. You fix the facet, you see the magic. I think facets, we have to learn more. What are facets? Why there is such a symptom of why blocking is not new. It is going on for several years. Even during my time, I'm not sure if Patkar remembers. We used to try. Dr. Vensalka used to talk about facet and stimulation of by leaching.
We used to cut the nerve. We used to put
Yes.
the 11 number blade and cut the
Yes,
sino-vertebral nerve.
That's right. That's right. During those days, Dr. Vensalka. So it is not a new procedure. It is an old procedure, but people have not understood it. World has not understood it. People have got experience here, experience there, but facets we have to still. I advise you, Ranjit, you just don't stop at where you have done. You try to understand this entity a little bit more, go further, and produce some remarkable, magical results which you can with your experience and with your hard, dedicated work. We should not stop. And I think the person who has not stopped is Dr. Patkar, who is sitting in front of me. He's also worked in a situation like you have worked. And you see, he has worked and he has produced and he's gone further. So we have to be believing in what we are doing and go further. Okay, Ranjit, I hope.
Yeah, so majority part of that presentation about blocks was localizing the pain, diagnosing the pain, diagnostic blocks, and that is very useful. Ozone, transforamen, these are temporary things. So basically diagnosing from where the pain is arising from to give yourself a surety. If you do something, is the pain going to go before you do something? So that was majority part. So that's what I think you were trying to say. Don't take away the pain, identify the pain and treat the pain.
That's right. That's right.
So today's discussion is really pretty long. We have been here for 1 hour and 45 minutes and excellent comment from all the stalwarts. And I think that all the happy faces, I can see that they got their answers. Too many younger generations, they are really like to see all these faces again and again. Thank you. Thank you, seniors. Thank you, juniors.
Thanks everybody for the chance and for the comments.
Thank you. Milind sir, thank you.
Thank you all.
Yeah, thank you. Thank you.
Bye.
Bye-bye to everybody.
Bye-bye, Patty.
Good night.
Sir, maja kara.
Oh.
Thank you, Dr. Giri.
Thank you, sir. Thank you. Thank you, sir. I'm extremely happy, sir. Thank you.